There was some motor weakness. Case 1. Neurological examination of the lower limbs of a young woman. There was some motor weakness in both legs, with upgoing plantars and hyperreflexia pointing to upper motor neuron lesion. I was asked to give a differential diagnosis. I listed demyelination and possible spinal cord compression from lesions, such as neurofibroma, as the most likely diagnosis.
Did you ever think of getting a cataract surgery fellowship in India? But we're confused as to which college or hospital is the best. Which city is the safest? Will there be accommodation provided? Whether you will be provided reliable transportation services from and to the airport along with clean food and water for the duration of your trip. I am Dr. Abid Nawaz, and I had all the same questions and I faced many of the same problems, which is why I started a service to help future fellows wanting to do their fellowships in India. Head over to phaconetwork.com and snag your free consultation with me and my amazing team. We'll help you find the perfect fellowship that matches your vibe, letting you train with certified pros at some of the coolest hospitals in India. Did I mention it's completely free? Level up your skills and kickstart your surgical ophthalmology journey with us. Let's make it happen. FACO Network. Let's go.
Including signs. Case 2. I was asked to take history from an elderly woman. She had right sudden visual loss suggestive of atrophy. I mentioned that the main diagnosis is between arteritic or non-arteritic ischemic optic neuropathy. This was followed by detailed questionings about the differences between the two, including signs, symptoms, and diagnosis. Case 3. The next patient had dysmorphic features with very short stature and hunched back. I was asked to examine her eyelids, and she appeared to have a right Horner's syndrome. I was asked to look at her irises on the slit lamp, which revealed bilateral Lisch's nodules. Questions on the different types of neurofibromatosis and the ocular manifestations. Case 4. Cranial nerve examination. The patient had bilateral facial weakness and also poor power of the tongue muscles. I gave a differential diagnosis of myasthenia gravis and oculopharyngeal muscle dystrophy. Questions on diagnosis of myasthenia gravis. Case 5. I was asked to examine the ocular motility of a patient with double vision. He had a small exophoria in the distance during cover-uncover test. Ocular movement revealed absent upgaze and poor vertical saccade. I asked for an opticokinetic drum so as to demonstrate convergence retraction syndrome, but there wasn't any in the room. I then proceeded to demonstrate the presence of light-near dissociation. The examiner asked me the possible causes of Parinaud syndrome. Case 1. Slit lamp examination of the anterior segment. The patient had bilateral obliteration of caruncles and shallowing of the inferior fornix. I made the diagnosis of ocular cicatrical pemphigoid. I was asked to give a differential diagnosis and the confirmatory diagnosis for pemphigoid.
Case 2. Ocular motility examination of a patient with exotropia. The tropia was constant and the deviated. I did not take up fixation. I was asked to examine the fundus of the affected eye with a direct ophthalmoscope. Unfortunately, the pupil had become constricted and all that I could find were cataract and possible fibrosis. I repeated the examination with a 20D lens and again the view was poor. However, the examiner said that he could see the view very well through the small pupil. Case 3. I was asked to demonstrate pupillary examination in a patient with dilated pupils. As both eyes were dilated with mydriatic, there were no reaction to light or accommodation. It seemed that the examiner just wanted to see how I can perform the test proficiently. On the same patient, I was asked to examine the fundus with a 78D. There were subtle macular changes in the right and I gave a differential diagnosis of early macular hole or cystoid macular edema. Case 4. Slit lamp examination of a patient with peripheral corneal thinning. There was pannus and lipid deposition. I made the diagnosis of herpetic stroma disease. Case 1. Take a history from this patient. Patient was a woman in her 60s. History revealed 4-year history of foreign body sensation and dry mouth. Patient had Sjögren's syndrome and questions on treatment, diagnosis and causes of Sjögren's syndrome. Also risk of lymphoma.
Did you ever think of getting a cataract surgery fellowship in India? But were confused as to which college or hospital is the best? Which city is the safest? Will there be accommodation provided? Whether you will be provided reliable transportation services from and to the airport along with clean food and water for the duration of your trip. I am Dr. Abid Nawaz, and I had all the same questions and I faced many of the same problems, which is why I started a service to help future fellows wanting to do their fellowships in India. Head over to phaconetwork.com and snag your free consultation with me and my amazing team. We'll help you find the perfect fellowship that matches your vibe, letting you train with certified pros at some of the coolest hospitals in India. Did I mention it's completely free? Level up your skills and kickstart your surgical ophthalmology journey with us. Let's make it happen. Phaco Network. Let's go.
Case 2. Spot diagnosis. The patient was male and had a significant stiff posture. He had a stiff lumbar vertebrate. The diagnosis was ankylosing spondylitis. Questions how the patient may present to the ophthalmologist apart from uveitis. The answer that the examiner after was difficult in looking straight due to the problem with the spine. I was asked what optical treatment is available for this problem and I mentioned vertical prisms which appeared to satisfy the examiner. Further questions on the management of rheumatological conditions focusing mainly on the adverse effect of steroid and immunosuppressants. Case 3. Examination of a patient's face. There were changes diagnostic of acne rosacea. I was asked to examine the anterior segment through a slit lamp. There were bilateral inferior corneal pannus and posterior blepharitis. Questions on the ocular complications of acne rosacea and management of the skin and eye problems. 4. Instead of patients, the examiners asked questions on the medical management of surgical patient. I was given a scenario of a diabetic patient who developed shortness of breath after vitrectomy and how I would manage the patient. The answers were focused on the management of diabetic patients pre and post operation and also the diagnosis and management of diabetic ketoacidosis. Case 1. I was asked to take a history from an elderly woman. She had an acute angle closure glaucoma in her left eye. Slit lamp examination revealed bilateral peripheral iridectomies and trabeculectomies. She also had bilateral pseudophakia. Questions on the management of acute angle closure glaucoma. 2. Examination of the fundus with 90D lens. The patient had a right deciform scar in the right macula, and in the left macula there was pigment epithelium detachment. Questions on investigation, including the advantages of ICG over FFA and possible treatment modalities including PDT. 3. The next patient was a woman in her 50s. Her right eye was dilated and the examiner asked me to examine the macula with a direct ophthalmoscope. The fundus showed myopic disc with Foster Fuchs spots. Then, I was asked to examine the left eye with a slit lamp. She had had a left LASIK procedure. Case 4. The last patient was a 65-year-old woman with a right esotropia. She wore glasses for her hypermetropia. Cover-uncover tests revealed esotropia for near and distance with and without glasses. The bell went before I had time to complete her ocular motility.